Good afternoon, everyone, and welcome to our Primetime Alive program, Why People Fall and How to Prevent Falls. I'm Vicki Newell with the Primetime Alive program here at Mary Greeley. As you'll see again, I got my mask in hand. I'm not wearing it in a large auditorium, and we can maintain physical distance. Dr. Kitchell's standing about 10 feet from me right now, and I'll move out so when he comes in, we're both safe, and then you'll be able to understand us better as well. Just a reminder to ask a question. You will not be able to open your microphone. You will need to type in your question. So you should have an arrow at the top of your screen. If you click that and open it up, it'll open it up something that looks similar to this, maybe not exactly, but similar. Towards the bottom, there is a box that says enter a question for the staff. If you type your question in there and hit send, it will add it into the queue for us, and we'll get to those at the end of our presentation today. Our presenter is Dr. Michael Kitchell. Dr. Kitchell received his bachelor's degree from Iowa State University and completed his medical degree and his neurology residency at the University of Iowa. He joined McFarland Clinic in 1979. He is also the medical director for Mary Greeley's Acute Rehabilitation Unit. Please welcome Dr. Kitchell.
So, hello, we'll go back one slide here to the beginning, if I can. Let's see.
I think that is the first slide.
Okay, all right, the title slide. Okay, well, I hope all of you are taking precautions to avoid the COVID virus. I wear a mask whenever I'm out and about or in my office. I am seeing about 75% of my patients by telemedicine, and so only about 25% of my patients I'm actually seeing in person. And so this talk is going to not only tell you how to reduce your risks of a bad outcome, but what are some of the reasons that people might have a bad outcome from falling. So just like COVID, I'm going to give you some advice today on how to reduce your risk of falling. Just like we want to reduce our risk of getting COVID by wearing masks, washing our hands, and keeping a safe distance. So this talk is both the reasons people fall and the results of what happens when people fall and how we can prevent them. So every 20 minutes in the United States, an older adult dies from a fall, and every 13 seconds, an older adult is treated in the emergency department for a fall-related injury. And then those of us who are over age 65, almost a third of people over age 65 during the last year have fallen once, but 45% of those people who fell actually had 2 or more falls, and a little over a third of the people who fall needed treatment because they broke something or they had a head injury and needed further evaluation. And I think it's pretty clear bad things happen when you fall. Most people who fall don't have a very serious injury requiring them to be in the hospital, but it's getting more risky for the older the patient and the more serious the fall. So about 800,000 people were admitted per year for injuries due to falls. And head injuries and hip fractures are the most common injuries that we see. I'm the director of the rehab program here, and so as a neurologist, I not only try to prevent people with neurologic diseases from falling, I unfortunately have to take care of a lot of people who've fallen and have either broken their hip, injured their back or their neck, or had a head injury, and those people are in the hospital for a lengthy period of time. About 20% of people who are elderly who had a hip fracture from falling actually died within 1 year. So this may be an indication that they are frail, but again, trying to avoid falling and breaking a hip is very important. So the numbers, unfortunately, are increasing, and nobody knows exactly why. There are obviously more older people as the baby boomers get into this age group, but about 33,000 deaths occurred in 2015 from falls, but only 8,600 people in 2000 had died because of falling. And it's predicted that by 2030, just 10 years from now, 49 million Americans will have a fall where they do have some, at least minor injury. One of the other issues, though, when we fall is a lot of people in our age group are on anticoagulants, and those blood thinners can make them much more likely to have a complication. If they hit their head, they are much more likely to bleed inside the brain, or if they have another injury, they're more likely to bleed into their body. Now, most people probably guess that if you're admitted to the hospital, it's pretty expensive. But whether it's the emergency department or an inpatient visit in the hospital, the total is staggering. It's $67 billion a year is spent for injuries due to falls. And that's a lot of money that we could have prevented us from spending. If you take all of the Medicare payments per year for heart attacks, for strokes, for cancer, 6% of those Medicare payments per year are due to injuries from falls. And Medicaid is even worse. 8% of Medicaid payments are for fall-related injuries. But that's because Medicaid actually pays for some of the nursing home after someone falls. Medicare doesn't pay nursing home care. So what is the average cost of a hip fracture? And it's pretty amazing. It's $50,000 is the average cost of a hip fracture. The average person who has a hip fracture usually is elderly, but it's an average of 5 to 6 days in the acute care hospital. And then if they go to rehab, where I'm the director here of the rehab program, they may stay another 10 to 20 days in rehab. So that's a long time that you're going to be away from home. And even after you get home, there's still more therapy to be done. The statistics show that 25% of the elderly, though, spend at least a year or more in nursing homes after a hip fracture. There are a lot of elderly people who are what we call frail, and I'll talk about that later. So we also see some other fractures like an ankle, leg, or pelvic fractures. Those can lead to hospitalization and rehab because people can't walk on just one leg. They have trouble getting around. The younger people might be able to do it, but a lot of older people can't. Wrist fractures and arm fractures also can lead to stays in the hospital because of the difficulty doing those things that people need to do at home. And as most people know, patients who have osteopenia or osteoporosis, that is weaker bones, they're obviously at a higher risk of fractures. So I think it's pretty clear, just like with the COVID virus, we need to prevent these infections. And there are some simple things that we do to prevent COVID virus infections, just like there are some simple things we can do to prevent falls. The cost to an individual who falls is great, but the cost to taxpayers or the group that insures them is also pretty high. As I said, $50,000 is the average for an inpatient hip fracture. Now, Medicare and other insurance companies realize that one of the things we need to do is prevent falls. And so one of the newer quality measures that Medicare has come out with is to have physicians be measured for how well they assess the patient's risk of falling. So if you come to the McFarland Clinic, in many of our departments, they will ask you some questions about how risky you might be for falling. And one of the questions is just simply, have you fallen in the past year? Because that's one of the best indicators that you're at risk of another fall too. But there is a risk assessment that's part of a quality measure dashboard. And Mary Greeley also tracks falls as part of Mary Greeley's quality and safety measures. I'm on the Quality Council at Mary Greeley, and one of our key indicators of harm to patients is whether people have fallen in the hospital. And as you probably have guessed, sometimes when people fall, it's because they are confused or they try to get up when they don't have any help. And this is what the hospital tries desperately, very carefully, to make sure that the patients here in the hospital don't fall. So these quality measures, as I say, focus on preventing falls, and there is an organization that McFarland Clinic is part of called an Accountable Care Organization. Medicare does contracts with physician groups and hospital groups around the country, and we have been what we call an accountable care organization that really focuses on reducing the costs of care. And if we prevent people from falling, there could be a potential reward because we are not spending that $50,000 on that patient. And if we keep about 20 people from falling, that's a pretty significant savings for Medicare. So Medicare rewards those physicians who have higher quality and prevent falls. So avoiding costly care is going to help everybody. Now, as I was saying at Mary Greeley, there's a big focus on trying to prevent some of our patients here who might be weak or confused or don't want to wait for the nurse to get there to help them to the bathroom. And so we have tried many different strategies, including people in the room. We might do alarms so that when people raise up off the chair, the alarm goes off. We have robots which will watch the patient. If they try to get up out of bed, the robot will say, please get back to bed. And so the nurses are constantly watching to make certain that certain people that are at risk of falling, like those who are confused or frail, that they don't fall. Now, I'm going to talk about conditions that increase risk of falls. And if most of you don't know what frailty is, I'm going to describe it a little bit more. Frailty is not just due to aging. When people are sick chronically, for example, a person who has the COVID virus infection and is in a weakened state, they could be considered frail. Frailty is a condition of weakness and having difficulty moving and getting around safely. It's not just aging. There are some people in their 90s and maybe even some in their 100-year plus age groups that are pretty vigorous and they would not be considered frail, but they have to work at it. So I'm going to talk a little bit more about some neurologic diseases, and one of these is called a gait disorder. Another one is called Parkinson's disease. These are fairly common problems with someone's walking and their balance. They have an abnormal gait, just like a horse has a gait when they're running or trotting. People who are walking can be either unsteady or their steps are short or they wobble. That's called a gait disorder. So I'll talk a little bit more about other neurologic diseases too, but Parkinson's disease is one that is pretty common and again, pretty likely to have some risk of falls. Now, blood pressure is an unrecognized or often not recognized problem that can lead to falls. When people have low blood pressure, It may not be low when they're sitting or when they're laying, but when they stand, their blood pressure can go from being normal, let's say at 120/80, the blood pressure can drop to 80/60. Well, that's going to make them feel woozy. That may even make them pass out briefly. So a physician needs to check the patient's blood pressure, both sitting and standing, if they have symptoms of dizziness, lightheadedness, or weakness when they get up. And that's a common problem when people might be getting too much medication, or when people are dehydrated. They may have a low blood pressure that might be normal when they're sitting or laying, but when they stand, it might be too low. Now, vertigo is a condition of feeling like the room is spinning, and people can sometimes describe it as dizziness, but not all dizziness leads to balance trouble and falls. Sometimes dizziness is a way of describing some difficulty with concentration or memory. But in any case, those people who have vertigo that leads to a balance problem are obviously at higher risk of falling too. So I'm going to talk more now about gait disorders. As I said, a horse has a certain type of gait. Neurologists are used to looking at people at particular times of their lives as to how they walk, how much spring is in their step, how easily they turn, how rapidly their arms move while they're walking. And so this is what we evaluate. We ask questions first to see whether they have a history of some balance difficulty. And if they say that they are dizzy, we need to find out what they mean by dizzy. Are they having vertigo? Are they just lightheaded? Do they feel woozy, like they might pass out? Or is it just more of a difficulty with their cognition, their memory, and their thinking? So when we examine a patient with a potential gait disorder, we watch them walk, we watch them do the heel and toe walking called the tandem gait. We do a test called the Romberg, which is keeping their balance with their eyes closed and open. We check for an orthostatic blood pressure drop. That is, our nurse will check them sitting and check them standing with the blood pressure. We also check their sensation in the feet, because sometimes when people lose the sensation of which way their toe or their foot or their ankle is going, they have balance difficulty too because of that sensory loss. Generally, when a neurologist sees a patient with a gait disorder, we will do a magnetic resonance scan of the brain. We'll particularly want to do this in the younger patients. And if it's an older patient where they've had a relatively rapid decline in their ability to walk, we do this in older patients. We might not do it in somebody who's 80 or 85 if it's been a gradual type of progression. But generally, if we are more worried about what is the cause, we will do that MRI scan. Vitamin B12 deficiency is sometimes associated with a balance problem because vitamin B12 actually helps to keep the spinal cord and the nerves that carry the proprioception, the position sense, to the brain. And if you're low on vitamin B12, that can affect your balance because it makes those sensory pathways affected. People can have vitamin B12 deficiency even though they may be taking enough vitamin B12, because many of the people who have vitamin B12 deficiency actually have a stomach problem where they don't absorb the vitamin B12. So when a neurologist sees someone who has a gait disorder, we always try to find a cause like Parkinson's disease, like multiple sclerosis, like a stroke, or a problem with a blood clot in the brain called a subdural hematoma. But if the workup is negative, then the neurologist will diagnose someone's problem with their gait, their equilibrium, their balance. We call it a gait disorder. Now, Parkinson's disease is pretty easy to diagnose in some people because they have a typical Parkinson's tremor, but about 25% of people with Parkinson's disease actually don't have a tremor, or it may be very mild. People with Parkinson's disease, though, will eventually have some difficulty with their gait. Their walking is slow, and when they are walking, they are somewhat unstable, particularly when they try to turn. They may shuffle their feet. They may have trouble getting up out of a chair or in and out of a car. They have trouble initiating their movement, that is, starting the walk or starting to get up out of a chair. They are slow. Also, people with Parkinson's disease have a loss of associated movement. And what I mean by that is when people walk, they don't have much arm swing. They may just have their arms rigid at their side, or they may lean forward, or they may lean to the side. Their posture is relatively stiff. Everybody knows what an athlete who's running fast looks like. They are using their arms to churn to help them run faster. But when you don't use your arms, even when walking, that's called a loss of associated movement. And people who have this with Parkinson's disease don't usually realize that they have lost that associated movement. People with Parkinson's disease on their exam have a slowing of their alternating motion rate testing. That is, when we test them for finger tapping or pronation, supination movements of their hands, those are often slowed. That's the same with the movements in their feet. They can be very rigid in the trunk or in their extremities. Their arms may be a little rigid, their legs may be rigid too. They can sometimes have freezing where they can't get started or they can't keep walking. They tend to freeze. So Parkinson's disease patients have a lot of difficulty with mobility. They have a decrease in their facial expressivity. They have a reduced blinking rate. They have a softer voice. They have some difficulty with articulation, and they sometimes drool and have some swallowing trouble. So these are all clues about whether someone has Parkinson's disease. And as I said, that's going to lead to a risk of falls. So as I was saying about frailty, this is a very common cause of falling. And as I said, we all get to be a little more frail every year that we get older, but it's not an inevitable condition. This condition of being weak and delicate is not always related to age, as I said, but it certainly is related to falling. People who are frail are much more likely to fall. And again, here are some statistics. People from age 65 to 74, 27 reported falls. And then as we get older, the percentage goes higher. About half of the people who are age 85 have some mild or moderate gait difficulties. And so by the time we all get to be 85, well, we may be using a cane, we may be using a walker. If you're 85 or older and you don't need a cane or a walker, that's wonderful. But there's still a little risk as we get older of more falls. And as I said earlier, frailty is avoidable if someone is motivated to stay active and exercise. And as we all know, when people have arthritis, either in the knees or the hips or the back, it can lead to less exercise. And so that alone, that lack of exercise, can lead to frailty. But arthritis in and of itself is not the cause of gait and balance difficulties. So I repeat, arthritis can lead to decreased walking, decreased exercise, decreased vigor, and can lead to frailty. And if you don't keep walking, you are going to get more frail. The other factor that is sometimes not recognized, just like I was talking earlier about the low blood pressure, it's medication. For example, if you are on a sleep medication, and especially those that are Ambien, Lunesta, the prescription type sleep medication, you are 9 times more likely to fall. Antipsychotic drugs used in psychiatrically ill patients also increase the risk of falling by 9 times. And then muscle relaxers, a lot of people take these because they've got neck aches or back aches or other muscular aches. Sedatives like antihistamines that could be used for allergies. Not all allergy medicines are sedating, but some are. Those also increase the risk of falling. Antidepressants don't have a 9-fold increase, but there's a little increase also with antidepressants. And as I said earlier, blood pressure drops when standing. Almost any medication that reduces blood pressure is going to increase the chance of an orthostatic blood pressure drop. So if a patient is on 3 or 4 different medications for blood pressure, if they were dehydrated, could they have orthostatic hypotension? Absolutely. You've got to be careful with that. And then obviously when people are on a lot of high potency, strong opioids, those are narcotics. Those are pain relievers that a lot of people are taking chronically. That impairs their balance, just like benzodiazepines like Valium or Ativan or Xanax can do. So those type of anti-anxiety medicines and opioids or narcotics are very likely to increase the risk of falls. There was a study of hip fracture patients, and they found that most of them were on 10 plus different medications prior to falling. We did a study one time on our unit here of a number of patients at Mary Greeley, and we had at one time, the average patient was on 21 different medications. That's not usual, but believe me, there are times that I see people on way too many medications. Okay, I'm going to talk more about some rare causes that are neurologic in nature, and I'm not going to spend too much time on this. If people have questions, I can answer that, but just want you to know what a neurologist does. There is a condition called progressive supranuclear palsy that's very similar to Parkinson's disease, and these people often fall when they're on the stairs because their eye movements are affected, their voice is affected, and they have swallowing trouble. But their main problem with progressive supranuclear palsy is they fall easily and often. Another disease, which is a lot like Parkinson's disease, but I'd call it Parkinson's plus. People have an orthostatic blood pressure drop. That is, when they stand up, their blood pressure just drops, and it's not related to medication, it's related to the disease. The disease affects their nervous system that controls their blood pressure. So that's called multiple system atrophy. There's also another rare condition called cortical basal degeneration. Some people who have strokes in the area of the brain called the basal ganglia or the cerebellum can have some balance difficulty. We do see people with multiple strokes too who have what's called a lacunar state and can have balance trouble or gait difficulties from that. The cerebellum is the balance center in the brain and can cause difficulty with walking and coordination because of multiple sclerosis, because of strokes, or some degenerative diseases. And then, as I said earlier, neurologists check for what we call proprioception, that is the sensation of position and vibration, and that can be affected in people who have a severe neuropathy. That means some nerve damage that would affect the nerves in their legs and feet. So someone with severe diabetes could have some sensory problems that lead to loss of balance. Another rare cause of the difficulty walking is called normal pressure hydrocephalus. Those people, though, not only have some gait difficulties, they also have some memory loss and they have incontinence of bladder control. They lose control of their bladder. So when a neurologist sees someone with a gait difficulty, that is, they fall easily, and they have dementia, and they have difficulty controlling their bladder, we do a workup to see whether they might have normal pressure hydrocephalus, which is actually treatable. Some people that we see have spinal cord pathology. Some of these people have arthritis in the neck that actually pinches the spinal cord, and it can come on gradually enough that they may not realize that this is actually due to a spinal cord problem in their neck or their upper back. Generally, people with lower back problems don't have as much trouble with their balance. They might have trouble with walking very far, but they don't have as much trouble with their balance if it's a lower back problem. And then I mentioned earlier, sometimes people with bleeding or clots in the brain called subdural hematomas can present with a chronic, gradual decline in their balance and walking. And that's why when people are older and they have a new onset of balance difficulty and gait difficulties, they need a neurologic workup. So as I was saying earlier too, dizziness is often a vague symptom, and it does need further evaluation, not necessarily by a neurologist. Obviously, some dizziness can be due to vertigo, and it can be easily treated by a physical therapist or a primary care doctor. So what we do when we see a patient with dizziness, we ask, is it intermittent? Is it triggered by movement or position changes? Or is it actually a feeling of lightheadedness, like they were woozy or they can't concentrate? It could be due to anxiety. It could be due to medications. And then some people, like I said, who have equilibrium problems, they will also complain of dizziness when they mean they have equilibrium problems and they are likely to fall. So again, the exam does help to sort out exactly what is the cause for some of these patients who have trouble with balance or dizziness. And as I said, many patients, especially older patients, are on too many medications. So if you are one of those, talk to your primary care doctor about maybe whittling away at those. So as I said, if there's an older patient with a new onset of problem with their walking, or if someone just says, I keep falling without any reason, that is, they didn't trip over the rug or the dog didn't run in their path, if they are frequently falling, they do need a workup to see why. And falling is predictive. As I said earlier, the more falls, the higher the risk of another fall. And avoiding falling is obviously much better than treating after you fall. Now, frailty, as I said earlier, it's not inevitable when we age. And the most important thing anybody can do for their body is to keep exercising as they get older, because exercise is medicine. We've heard that from Iowa State researchers. We've heard that from lots of other experts. There is good evidence that exercise can lower your blood pressure, can strengthen your bones, can improve your heart function, can improve your lung function, and can improve your brain function. So please be active. And aerobic exercise is movement. It's getting your pulse rate up a little bit. It might be a little short of breath. It's not extreme exercise. It can be just simply walking. And if you like to do something else, please take advantage of these exercise programs. Primetime Alive has a lot of exercise programs that are available, although the COVID virus has obviously cut back dramatically on a lot of these group gatherings. There is an Iowa State website called Walk with Ease at iowastate.edu, and there also is a site called Exercise.org, and you can see that in my lecture notes. The city of Ames, again, is limited because of this COVID virus, but the city of Ames Parks and Recreation has a really huge number of opportunities that anybody of any age can take part in exercise. I read their brochure and I was just amazed at how many things they offer. And then Heartland Senior Services, they do a great job of giving people multiple opportunities to be involved with exercising. And again, I just hope this COVID virus situation will be over soon so we can all get back to our group activities, because it's really cut back on that obviously a lot. And then if you like to go to something on the internet, the National Institutes of Health has a really good website. It's nia.nih.gov. Again, that's in my handout for this program. I do tell people, though, that even though they need to exercise, even though they need to keep from being frail, I tell our other physicians, please refer patients who are frail, please refer people who have difficulty with their balance, get them to a physical therapist. Like I say, if there's a diagnostic question, they may need to see a neurologist. Go to your primary care doctor, though, first and see if they can help sort out what the problem is. And then, like I say, physical therapists are experts at helping people who have gait difficulties and balance trouble. Physical therapists in particular are very good at treating people who have positional vertigo. They can do some quick and easy exercises to help people get over positional vertigo. That is when you roll over in bed or when you turn quickly and you suddenly feel like the room is spinning. That's the type of therapy that a physical therapist can offer. So summarizing again, how we can prevent falls. Get yourself into an exercise program. Do it over the internet or watch something on TV if you need to have other people help motivate you, whether you like to walk or whether you like to garden or whatever you like to do, just keep doing it regularly. And then, as I said, review your medications. I know people sometimes need to take some sleep medication to help them sleep, but just be aware it's going to raise your risk of falling, not just at night, even during the day. And then people who are on muscle relaxers, if you are taking a medicine chronically because of neck aches or back aches or shoulder muscle pain, just be aware these muscle relaxers will make you at higher risk of falling. And then antidepressants, and then people with more serious mental illness that are using antipsychotic drugs, those also increase the risk. And then it's always good to have your vision tested yearly, especially in the dark when people are walking in their own home and they forget that they had a throw rug in that pathway. They can trip over the throw rug because they don't see that. Or if they're not paying attention, their dog or their cat can get in the way and they can fall because of that. We need to have everybody make their home a safer environment. You need to remove clutter. You need to get rid of the throw rugs. And if you ever get up on a ladder, you'd better be absolutely certain that the ladder is stable and you don't tip over one direction or the other. Ladder safety is so important. I've taken care of too many people in the rehab program here at Mary Greeley who are up on a ladder or up on the roof, and boom, they suddenly lost their balance, and then they had multiple fractures and injuries. So if you don't have grab bars in the shower, you might want to think about that. You want to have handrails. You want to have non-slip mats so you don't slip easily. You have to have good lighting. Have a night light so that when you're getting up to the bathroom at night, there won't be something in the way that you won't see. So night lights are important. And then, of course, good footwear, especially if the weather's bad. We're going to have some bad weather again this winter, no doubt. And so any icy, slippery surfaces, you've got to be wearing good footwear and then get some either sand or something to melt those icy spots so you don't have a slip and fall. We often see people coming to the emergency department after an ice storm, and it's just amazing how many people get injured even though they know it's icy out there. So you've got to take extra care. And then, as I said earlier, a physical therapist who I refer people to, and I recommend even a primary care physician, the more severe the person's gait or balance difficulty, the more they will need physical therapy. They might need a diagnosis from a neurologist first, but they will need formal physical therapy if the balance trouble is severe. And I know a lot of elderly people don't want to use a cane. I know they don't want to use a walker, but it's a lot less embarrassing using a cane or a walker than falling down and then having somebody call an ambulance to take you to the hospital. So I know most people don't want to use a cane or a walker, but believe me, it's a lot better than getting embarrassed by falling and needing an ambulance to take you to the hospital. So how do we detect the increased risk of falling? And there have been a lot of instruments that have been tried, but there aren't any real clear ways. Our fall risk assessment, just asking questions about people, is really our best risk tool. There is one test called a timed up and go test that can help to detect risk, but it's basically what a neurologist would do. We would say, get up out of the chair and walk to the corner and back. And that's a way that a neurologist can help watch people walking and watch their gait to detect the risk of falling. And so a lot of tests that you might read about over the internet or somewhere, they don't have much value in detecting what the risk is. But early intervention by using some exercise to keep from being frail, or multifactorial interventions, both exercise and some training, have been shown to be of benefit in preventing falls. And as I said, physical therapy should be offered to everyone who has a high fall risk. Gait, balance, and functional training is a little bit better than resistance training. Resistance training is like weightlifting. Flexibility training is stretching and limbering up exercises, but that's not as good as just the functional training that a physical therapist will do. And then endurance training is helpful, but it's not going to be as helpful as just doing the functional things like gait and balance activities. There have been some exercise interventions, for example, Tai Chi. I know that Primetime has been involved with Tai Chi classes, and those are very good. Yoga is good, and various dance therapies are good. People have asked about vitamin D and calcium. Unfortunately, they don't reduce falls, but if you have a low vitamin D level, you are at risk of breaking a bone. And so if you want to take some extra vitamin D and calcium, it's not going to be harmful unless you take too much. They actually did a study where people took too much vitamin D, about 4 times the daily requirement, and those people actually had more difficulties. So just make sure if you're not drinking milk and you don't have much vitamin D, make sure you add a little bit to your diet. And as I said, other things like cognitive or behavioral therapy, social services might be somewhat helpful, but it's mostly to get people into an exercise program or a way to reduce their frailty. So winding up here today, my key points are, number one, a history of falls is the simplest tool to detect the risk of another fall. So if you haven't fallen and you feel pretty steady, you don't need to have any risk assessments. But if you're frail, you definitely need to do some more exercising, and it definitely reduces your risk of falling by correcting some of the frailty that a lot of people fall into through sometimes no fault of their own, too. And as I said earlier, I just want to harp on medication and the blood pressure drop when you stand. It's not blood pressure when you're sitting, it's blood pressure when you're standing. So those do need to be checked. So if you have a blood pressure machine at home, check it for your own safety. And then I do tell people, if you really have a problem with your gait or your balance, the best specialist to evaluate that is a neurologist. And a physical therapist is really valuable for treating people who have gait difficulties and balance trouble. So I will open up to questions now, and I presume we probably have a few.
Let's see here, we can click, there we go. He's opening them up there. Oh, as of right now, we do not have any questions. You must have covered everything so well. We'll give it a minute and see if we have some questions that pop up. And if not, well, we'll kind of close it up here, and if any questions pop up, we can.
Well, I'd like to say a little bit more about the COVID situation. I wear a mask whenever I'm in a public area indoors, and that means at the hospital, in my office. I don't think that's too much to ask, and I hope that everybody will wear masks when they're out in public, especially indoor spaces. I hope everybody goes to the football game will be wearing a mask. I think people who downplay the benefits of wearing a mask are really doing a disservice to people, because wearing a mask is the most important thing. Social distancing is important. If you're outside and you're 10 feet or more away from somebody, there's probably very little risk. But again, washing your hands is an important part of this. So masks, social distancing, and washing your hands. So just be smart about preventing an illness from COVID, and be smart about avoiding falls so you don't get to be one of those people up on the rehab program that I'm taking care of with a broken hip.
Very nice. Thank you, Dr. Kitchell. Great presentation, great handout. I know people will probably keep this and share and refer other people, and this will be out on our YouTube channel as well for people to watch. So sorry, I keep touching my mask, and I know you're not supposed to do that, but I will have my mask on at the football game Saturday night, and I think if people don't have them on, they will be escorted out. So go Cyclones, and thank you, Dr. Kitchell. It was a great presentation. Did you have one more thing you wanted to say?
Yeah, I just wanted to say Vicky's son is the center for the Iowa State football team, and we're cheering them on, and hopefully he's going to remain safe, both avoiding COVID and avoiding injuries.
Well, I appreciate that, Dr. Kitchell. Thank you for joining us. Everyone, stay safe out there from COVID and from those falls. You can protect yourself for both. So have a great day, and thank you, Dr. Kitchell.